Well, with that beginning again, I was making a comment on slideology, but obviously there needs to be a book out on virtual meetings. Now, with the virtual meetings, and then one distributes the slides later on, it's nice that there's more verbiage within the slide, so I'm violating that rule. Number one, regarding good slides of reducing verbiage. My objectives are really to acknowledge the history and authors of the development of the major classifications of radioiodine refractory, to distill the classifications of those radioiodine refractory of differentiated thyroid cancer, and most importantly, to list the literature and the supporting of those classifications, as well as the limitations of those classifications. So I want to propose in a second presentation objectives of next steps for revision of those classifications, and this will be a presentation after Marcus's, and to submit potential approaches and caveats to help manage and minimize patients from being excluded from an I-131 therapy that may potentially help that patient. And I will conclude with a discussion of future areas of research. Now, there have been many, many individuals through the years that have really developed and progressed with the definitions or classifications of radioiodine refractory disease. And although I'm going to make additional suggestions, I want to acknowledge their initial efforts and innovation and creativity in trying to address this issue earlier on. This was a thyroid conference in 2010, and Brose, who's now in Philadelphia, published an article really first addressing what radioiodine refractory disease was or is. And then there was a larger meeting of panel of experts in 2012 in Pisa, Italy. And in this meeting, multiple individuals met, and Dr. Schlumberger, Martin Schlumberger from France, published the definitions and management of radioiodine refractory disease. Subsequently, there have been many more publications building upon those initial and outstanding efforts. Tuttle has a nice article out. Sachs from Los Angeles has an article, and then the Thyroid Association published in 2016 the 2015 ATA guidelines by Brian Haugen. And again, there are many more, but I want to recognize these individuals. Then there was a group that met in Martinique, the island of Martinique, which of course everyone thought we were going on a boondoggle. However, while we were there, we're sitting in a conference room for 2 days while everybody else is out swimming and sunning, and we're struggling with various controversies within thyroid cancer. And this Martinique working group was formed by the European Thyroid Association, the American Thyroid Association, the European Association of Nuclear Medicine, and the Society of Nuclear Medicine. And several of the speakers at this program, including Ben Greenspan and Marcus Luster, were all on that. And out of that group came Martinique Principles, which I encourage one to review, which was very valuable. And in there, radioiodine refractory was addressed. And we're going to address some of those issues from that meeting, as well as from the 2015 final ATA guidelines. And as I mentioned, or will mention in a minute, the most important issue is to address the limitations. However, this is one of my favorite slides to make sure we're doing what we think we're doing. We all think we're doing the right thing. Our intentions are good. We all want to do the right thing, but are we? My objective is to inform you regarding some of the limitations of the definitions, or I prefer the word categorization or classifications of patients with differentiated thyroid cancer that are classified as radioiodine refractory. I agree with a statement that was published in the ATA guidelines that when a patient is truly radioiodine refractory, and the emphasis is on the operative word of truly, then the patient should not receive any further I-131. But as I noted, the operative word is truly. I'm also, and I'm stating this very clearly because frequently at subsequent meetings, humbly, I get quoted and I'm not quoted correctly. So I am in full agreement that any patient who meets one or more of the above classifications, or rather the classifications that are going to follow, has a higher likelihood of being radioiodine refractory than a patient who does not meet one of these classifications. The issues for me are they are frequently taken as definitions, sacrosanct, de facto, inviolable, and they are not. The key is knowing the limitations behind what's called a definition. And unfortunately, in my opinion, the limitations are becoming less and less frequently discussed and less extensively discussed. Now, I'm not the mafia and I'm not the cancel culture. I'm not trying to cancel any guidelines. I'm not trying to tell you what to drink or what to do. Rather, what I'm trying to do is to emphasize that guidelines, despite our disclaimers that they aren't guidelines, are often taken as definitive and etched in stone. My goal is I just want you to be informed about the limitations, and then you can practice medicine with your patient. I love this from Mark Twain. It ain't what you don't know that gets you in trouble. It's what you know for sure, or you think you know for sure, that just ain't so. So let's take a look. Here's classification 1. Malignant tissue does not concentrate radioiodine on a diagnostic scan. Now, it's not a sacrosanct classification. And let me show you some of the literature on that. First of all, there's limitations with it, and there's poor scan preparation, no history of recent iodine load, or no checking of urine iodine levels. Those patients with thyroid hormone withdrawal, no checking of the TSH. All of these would obviously affect the quality. Now, as many of the individuals who are on this virtual meeting know, they probably practice this, but these can affect the quality of the scan and actually take a positive scan and make it negative. Limitation 2, not all scans are created equal. Here's an image of a patient with I-131, and here's an image obtained with a different technique. And one may say there's potentially 2 metastasis here, but it's not convincing. And this is GI activity, and here's some heart blood pool activity neck up here. And this image was performed 24 hours later. And what one sees is clearly 3 areas of activity. Not all scans are created equal. These are 3 metastases, and either a SPECT scan or lateral oblique images would help localize these to either the lung and or to the rib. Not all scans are created equal. And there's many tricks. I won't go through all of these. However, these have been addressed in a separate article that was in Thyroid in 2019, volume 29, page 901, start. So one can go back for details on that. If you're an endocrinologist and you're referring to your nuke med physician, you may or may not see your scans, and certainly you most likely don't know all the techniques that are or are not being used to maximize what one finds on a diagnostic scan. Limitation 3, many diagnostic scans are negative, but in actual fact, the post-therapy scans are positive. So they're not, certainly they're not, they may still be radioiodine refractory, but they're not radioiodine negative. Now, what's the data for that? Here's 6 articles, 69%, 25%, 64%. These are the number of patients who had a negative diagnostic scan, got a blind therapy, blind meaning that the scan was negative, and then showed up areas of I-131 uptake on the post-therapy scan. Here's additional articles from 7 more. Now, I don't think it's 94% and 94 and was 80 over here. These are significant numbers, even if they're only 25%. The key is that diagnostic scans that are negative can still be positive on the post-therapy scan, and thus they have avid radioiodine thyroid tissue or cancer, and they may respond to a radioiodine therapy. Classification 1, definition 1 that was listed in the 2015 guidelines, excellent guidelines, by the way, by Brian Haugen and the team, says that if this cancer does not concentrate radioiodine on a diagnostic scan, it's radioiodine refractory. It's not a reliable classification, even with appropriate imaging technique. The second classification, malignant tissue does not concentrate radioiodine on a post-therapy scan. This is one of the better classifications. However, this is not sacrosanct either. And some of the literature on this is from Salvatore. Now, if one performs a post-therapy scan and performs it on day 3 and day 7, they will be positive on day 3 or day 7 in 80% of the cases. Thus, you could perform your post-therapy scan on day 3, 4, 5, 6, or 7, and if there's going to be uptake, you'll detect it in 80% of those patients. However, if you only perform the post-therapy scan on day 7, but not day 3, 7.5% were positive on the day 3. This is Salvatore's data. If you only performed a scan on day 3, but not day 7, you would have missed 12%. So in other words, just because a post-therapy scan is negative is not sacrosanct. It's not by definition indicative of radioiodine refractory disease. Now, that's not the only study. So, the argument is find a study to support your opinion. And again, my opinion is knowing the limitations, but there are many other similar studies that have been published. Salvatore's at the top. I'm not going to go through this with time. Hung, Lee, Chong, Kadani. As Deidre noted in the beginning, these slides and videos will be available. And certainly, I'm going to include my own email address at the end, and you can request them directly from me. So there's multiple publications that show the timing of the post-therapy scan will make a difference in whether you see radioiodine uptake. For classification 2, does malignant tissue concentrate radioiodine on a post-therapy scan? It's a good, but it's not a sacrosanct classification. Know your limitations. Now, the frequent question that I usually get at other meetings is, well, how do I handle that? And the problem is, I don't think my administrator is going to be happy about performing a scan in 3 to 7 days. That's just not going to happen. There's no reimbursement. It takes a lot of camera time. However, one can perform a scan in 3 to 4 days We were frequently performing scans at 7, but have been advocating performing scans at 3 to 4 days. If it's positive, it's positive. And if it's negative, and you have a high suspicion of metastatic disease, let's say you have a lytic lesion on CT, or you have a significantly elevated TG, consider repeating that scan at 6 to 8 days. So you've dramatically reduced the number of patients that are getting 2 scans, but you're improving your ability to detect those patients who may have metastatic disease that's negative at 3 to 4 days, and not inappropriately call that patient radioiodine refractory when they are radioiodine avid and may benefit. I said may, I didn't say definitely, may benefit from an I-131 therapy. Classification, good, but not sacrosanct, so know the limitations. Number 3, the tumor loses the ability to concentrate radioiodine after previous evidence of radioiodine disease. Exactly the same argument as I just presented. Classification 4, radioiodine is concentrated in some lesions, but not in others. This, in my opinion, should not be a classification. So I have 4 bone lesions that take up radioiodine, but 1 bone lesion doesn't. Does that really characterize the patient's disease as radioiodine refractory? And I would argue that, well, why not treat non-avid I-131 bone lesion with focally directed treatment, surgery, XRT, a cyber knife, embolization, radiolabeled emboli, etc., and then administer the I-131 treatment for the other bony lesions. This should not, in my opinion, again, be a classification. Classification 5, disease progresses despite significant concentration of radioiodine. So the lesions get larger, and you've treated it with radioiodine. This is one of the most important classifications. However, what's the limitation? The limitation is in the operative word of progresses. It needs more specific criteria than just the fact that the patient is progressing. For example, if the patient is progressing after a therapy of an activity of 100 millicuries of I-131, why is that considered radioiodine refractory disease as opposed to if you allow me, a radioiodine refractory physician? That may not have been enough. Likewise, if the patient is progression free, so let's say the patient was progressing, and then the patient got I-131, and the disease became stable and stabilized for 14 months. Now, why is that considered good for daily administration of Lenvima and refractory for one administration of the I-131 14 months earlier? I say that's a good response, and that the patient should really get another therapy with I-131. The key is the word progression, which needs further categorization. Again, why not give another I-131 therapy? Now, in my second part of my presentation, after Marcus Luster, and maybe Deidre and I can figure out why I can't just put the primary slide up, we'll address some of those factors. Classification 6, the patients received a total of 600 millicuries of I-131. So they've got multiple therapies. They've reached 600 millicuries. By definition, that patient is now radioiodine refractory. In my opinion, there should not be a classification. Now, where did this come from? Why 600? This is based on predominantly 2 major reports. One was from Durant in JCEM, and the other one was from Wong from Clinical Endocrinology, and that it was unlikely that the patient would benefit with I-131 above 600 millicuries. Let's look at that. Let's look at their articles. Durant reported 4% of patients had a response above 600 millicuries, above 22 gigabecquerels. Wong had 12% of patients who had a response. Now, one might argue, well, 4% is too low to consider another therapy, but these patients are running out of therapeutic options and they're progressing. So 4% for me In fact, as I digress for a minute, I had a recent surgery myself, and I asked what the mortality rate was for the surgery, and they said, oh, it's very low, 1%. Well, in my opinion, 1% is high. So in my opinion, this is a patient who has progressive metastatic disease, and 4% may still respond. How do we find that 4% so that we don't exclude them from another I-131 therapy? And 12% certainly bothers me. So in my opinion, what really is important is if the patient had more than 600 millicuries and received an adequate dose of I-131 and responded, then consider another I-131 therapy. If they had less than 600 millicuries and did not respond, then consider them potentially radioiodine refractory. And later I'll again talk, but how much were they receiving? Were they getting 75 or 100 millicuries for this metastatic disease? That's not necessarily radioiodine refractory. That's potentially insufficient administered activity. And there are other factors before classifying a patient as radioiodine refractory, just in regard to not only response, but many other items. So in my opinion, this should not be a classification. Progression with a specific criteria is a better classification. So in summary, and I hope I brought us back on time schedule to make up for that lost time, what I tried to do is recognize the excellent efforts of the earlier authors. And as the old cliche says, we stand on the shoulders of giants in the development of the major classifications of radioiodine. We need to I distilled those classifications of radioiodine, and I listed the literature and the support documents. But what we really need to know, and we discussed, is the limitations of those classifications. Now, what I'll do in part 2 after Marcus Luster is we'll be talking about improving diagnosis and treatment profile of RIA, and really we'll be looking at the management in the present state of our knowledge of radioiodine refractory disease.